Hi, my name is Ryan Larson. I'm a family nurse practitioner and I specialize in palliative care. I went to nursing school through DATC in Weber State and got my NP through a school in Boston. I was initially asked to come and meet with you guys at a post conference and um, to try to kind of go over palliative care and hospice care and do some education, but our schedules are busy, and Chantel had this idea of me throwing together a video for you guys to be able to be played at post conferences and stuff like that. So I kind of wanted to start out with the story of when I first started palliative care and working in this role in 2018. I remember when we'd first go into a patient's room, and sometimes the hospitalist doctor who would consult our place of palliative care consult will sort of give the patient and family a heads up of, like, hey, I've got this guy, this team that's going to come meet with you. They're called the palliative care team. And a lot of times, by the time we would make it to the patient, they will have maybe already had conducted a Google search. And I remember back in at that time, again 2018, that I would find that families would have had Googled palliative care, and by the time I would come in, they thought, "Oh, here comes hospice care. Here comes the end of life team," and a lot of it is because I ended up Googling it myself back then, and I found that a lot of the definitions for palliative care, number one, there weren't a lot of good definitions, and if there were definitions on there, they would have, it would look more of like hospice care. So I can see why people thought that, and so that was kind of a barrier. It's not so much anymore. I've conducted searches recently and found that there actually are some good definitions out there that don't make palliative care look like hospice care. And honestly, this is something that a lot of current practicing physicians don't fully understand. So if you guys have been confused and maybe felt dumb for not understanding palliative care versus hospice, don't beat yourself up. It's complicated, or it can be complicated. So how I sort of explain palliative care as is a medical specialty that works with individuals who have serious medical conditions that are life-limiting and or life-ending in nature. And the focus of our care is aimed at improving quality of life or enhancing quality of life in ways that we can. And so how do we do this? Part of it is with what I do, and that's with increased and sometimes more aggressive symptom management with medications. Or other measures, and the other part of it is increased psychosocial, spiritual, and emotional support from the interdisciplinary team, and that's made up of social workers, chaplains, RNs, nurse practitioners, PAs, physicians, and so all of this extra support that we provide. You can kind of think as palliative care as an extra layer of support. That's another term that I like to use. All of this kind of care and support is provided with goals of care conversations. And these goals of care conversations are meant to help clarify goals of care. So we do this by helping the individual understand their underlying illness in conjunction with whatever comorbidities they might have that's driving their decline. And we also help them define what's most important to them, and ask questions like, knowing what you know about your medical condition, what's most important to you at this point in time? Or you ask questions like, what are you hoping for? Those simple questions can oftentimes give you a lot of good information and insight in how to better take care of these people. So what does an actual patient look like? So, or what does a goals of care conversation look like? So, it can vary. It's wide ranging. Sometimes our goals of care conversations might be a one and done meeting in the ICU with a critically ill patient who we're having to talk with family about you know, about things like when do we, how long do we keep going at this? And, looking at what options are available to try to focus more on keeping someone comfortable. Um, and and sometimes during these meetings, what we do is we help people understand what's realistic and what's achievable. For some people, it might be something like, geez, I just want to be able to get up out of my recliner and ambulate to the bathroom without experiencing severe air hunger, because maybe they have some heart failure or pulmonary disease. Or another goal that might come up from one of these goals of care conversations is, I want to make it to my grandkids' high school graduation or a wedding or some other family event. Another example of something that you might see as a result of a goals of care conversation is a DNR resuscitation or a code status. And this might be a DNR code status might be something that has come from as a result of a goals of care conversation that took place at some point in time earlier on. And so in some of these patients, you could have a DNR code status, but they still have, that's their only line in the sand. They want everything else up to that point. And so that DNR code status, again, just might be a result of a line in the sand that they established with a goals of care conversation. Maybe it didn't take place with a palliative care team. Maybe it was just with their primary care provider or, a hospitalist or something else. So another example of a patient, for some of our patients, their goals may be restorative and they want the medical care to be as aggressive as possible. And they don't have any limitations at all. So this could be an ICU patient on a ventilator with vasopressors, and they have a full code resuscitation status. That doesn't sound like your typical palliative care patient, and it's probably not your typical palliative care patient, but we definitely have a lot of patients who are, wanting to still be aggressive and restorative with their care, and that's okay. It's not our job to take away hope from people, but at the same time, it's important that we are meeting with patients and families and making sure that we're updating them on their, kind of everything that's going on, and making sure that they understand the full complexity of what's going on. And sometimes it can be not just their complexity of their medical condition, but of their social situation as well. Social dilemmas and issues, they come in all shapes and sizes. And so it could be someone who, a patient and family, they have the patient who's been sick for a long time and caring for them at home. And, as their care needs increase, the ability of family to provide that care is kind of taken away. And so at that point in time is when we ask our social workers to, figure out what resources might be available to help this family out, and in being caregivers, or also, maybe it's the fact that the patient, we have to go tell the patient, hey, we no longer can, keep you home. You're going to have to live in a facility and be dependent on caregivers to provide care for you for the rest of your life. That can be a pretty tough bomb to drop on someone, and and it can be really beneficial to have a social worker there to help them cope with this huge change in their life. And sometimes it can just be having someone to talk with. That's a lot of what they do, and people can find a lot of benefit from that. And so another palliative care patient might be someone who maybe was like an athlete, or someone who's always on the go and always moving and doing, and they have this underlying condition. Again, it could be heart failure, it could be pulmonary disease, it could be cancer, anything that is sort of chipping away at their ability to do those things, to be that doer and that goer, because their ability to do these things has brought them quality of life and has sort of partially defined their identity as a human being. This could even be something like just being able to work out in the yard, or maybe just being able to live independently. So one thing that I've learned in my time in this job is that I'm always blown away at sort of the ramifications that can come when someone's identity is sort of chipped away at by a disease process that they really have no control over. It can be really hard to watch, um, and so it's, as a medical provider for these patients and these individuals, we need to be aware of our limitations as medical providers. There's only so much that I can do as a prescriber on the team, and giving someone a new medication, and hoping that it's gonna, fix someone. Sometimes it's just putting a band-aid on a problem, and sometimes it can make matters worse if we're just masking some underlying psychosocial or spiritual or emotional issue that needs to be worked through. Just because someone might be nearing the end of life doesn't mean that we quit trying those types of things. And whenever we see someone who's struggling with something like this, this is when we consult our chaplain. So this person's identity is being impacted, or their spirituality. Oftentimes, in fact, I would say most of the time when I get a chaplain involved on a case, it doesn't have anything to do with religion like most people would think. And I would love for the chaplain to come by and be able to come by and meet with you guys and sort of explain the role of the chaplain a little more. We currently have one chaplain here, and it's the palliative care chaplain, and he sees more patients than I do, so he's really busy. They're working right now to beef up chaplaincy system-wide, so hopefully here soon we'll start seeing a lot more of this role. And I want you guys to keep in mind that this isn't, you don't just call the chaplain after someone has passed away and they need someone to pray with family or whatever. I mean, you can, obviously, that's a great time to call a chaplain, but I would say anytime that you are working with a patient and they're struggling with finding acceptance, that would be a good time to consult the chaplain. And you don't need to ask for a medical order or anything like that. You guys can, as nurses, you can contact the chaplain and have them meet with a patient or a family member. So what else do we need to hit on here? Our social workers. So the role of the social worker, again, is huge. It's something that I think one of the biggest benefits of having the social worker on our team is not only providing psychosocial and emotional support to the patient, but they're really good at taking care of the family members, especially the family members who may be acting as a caregiver. So caregiver burnout is something that it's complicated, and it's a sneaky devil. It chips away. Here you have, this chronic health condition that's chipping away at the identity of the patient. And then, you sort of see this caregiver having their identity chipped away at as well. And what I mean by this is they're no longer, wife or daughter or husband. They don't get a function in that role anymore with someone taking care of someone who's chronically ill. Their role is caregiver. They're no longer husband, wife, son, or friend, or whatever. They're functioning as a caregiver. And it's not easy. And a lot of times it can cause feelings and emotions to surface that are, that look like resentment towards that person in some cases. And so it can be really sad when you have, a wife that loves their husband so much, the husband who's suffering from a chronic condition, and all this wife's job is waking up and taking care of, her husband, providing care for him, and it can be wearing on families, and whenever you see someone struggling with caregiver burnout is a good time to reach out to a social worker, whether it's a palliative care social worker, a unit social worker, or just making a recommendation to them to reach out to a therapist or something. And so, you have these palliative care patients that can kind of come in all different varieties, whether we're catching them upstream and they're someone we followed for years and years, or a patient who we've never met before and they come into the ICU critically ill, and we're going to have a one quick goals of care meeting with family. And so another patient that you might encounter is someone who has gotten to the point where they've been sick for so long and their quality of life is just not there anymore. And when you look at someone or a patient and you think, geez, is this person existing, or are they living? Or I guess we can reverse that. Is this person living, or are they just existing, is how I would word it. Or, are we prolonging life here, or are we prolonging suffering? When those questions start to kind of come up in your mind is when you should, probably start to consider placing a hospice consult. So hospice care is a shift from restorative care to focusing on comfort and quality of life. And this is done with even more so aggressive symptom management, but it's not with the intent of hastening the dying process or anything like that. Not in this state anyway. But we don't really try to slow anything down either. We allow patients to kind of eat and drink whatever they want. And we have all of their care brought out to them. So we have nurses that are on call 24/7. You'll have a CNA, and that's one big difference. One key difference between palliative care and hospice is the CNAs, and really the extra manpower that you would get with hospice care, because you're having nurses and CNAs come in. Sometimes they can come in 5 or even 7 days a week, depending on what the hospice patient's needs are. And in addition to those core team members, the CNAs, social workers, chaplains, nurses, volunteers, those are the core team members that hospice agencies will have. And some agencies will have ancillary services like music therapy and massage therapy. I worked for a hospice company early on in my career that I would do hospice recertifications for, and I can sort of explain that another time to you guys. But what I found was that I would go out to recertify some of these dementia patients, and they could be so far along in their disease trajectory that they're nonverbal. And this music therapist would come out and she would play songs, maybe their old church songs or songs from their childhood, and you would have this nonverbal patient go from really not doing anything to humming along to this old tune that they once knew, or sometimes we'd even see them singing along, which was crazy, and I would have never believed it had I not seen it with my own two eyes. So kind of a funny story is my wife is a hospice nurse, and she happened to work at that agency that I was just telling you about. And I would joke with her saying like, geez, here these people are able to sing tunes that, or hum along to tunes that they grew up listening to. It's going to be pretty scary someday when we're old and we have music therapists coming around and you have residents humming along to Taylor Swift and Nicki Minaj or other artists. I think that's kind of funny. It'll be interesting. Can't wait for that day to come. So anyway, working with hospice patients, it really can be a neat experience. A lot, just like palliative care, but even different. And what I mean by that is that the experience as a caregiver can be different because of one key thing, and this key thing, this event, I'll call it, that takes place in a lot of hospice patients is their ability to have found acceptance for what's going on with them and acceptance with the fact that they are dying. And I've seen it in my own sort of limited experience and in what experience I have with hospice, but my wife tells me stories of how neat it can be being that hospice nurse and going into a family who has found acceptance with everything that's going on. And it seems like that things that once mattered to them, that we make a big deal out of, don't matter anymore. And that things that, the little things in life really are what they are able to find joy in. And it's an entirely different experience in a lot of ways when you're taking care of a hospice patient versus a palliative care patient. So if you guys have hospice or friends who are hospice nurses, you should ask them about some of their experiences. Most hospice nurses who I've met with are able to, kind of share similar experiences, and they have some really good insight and stories to share. So that's all I have for you guys today. I hope this was helpful. I'd eventually like to get to the point where I can have some slides thrown together for you guys, and I can go into more detail on some hospice criteria and different resources that might help you guys out. Thanks for your time.